first and foremost, we need to acknowledge that structural racism is a crisis, and we haven't done that uniformly. There are certainly some states that have, and some, obviously maybe more progressive individuals who have, but certainly that's a portion, a percentage of what we need to do. But, in addition to that, we need to look at the community and look at our relationship to communities. The reason why communities are, sort of outside the process, they're marginalized, they're not necessarily engaged in the healthcare system, is because there's been disinvestment over decades. Okay, so what we need to do is reinvest, build capacity. Even while we're in this emergency phase, we need to be thinking long term. What can we do with these, if we're talking about drive-through vaccination, pop-up, mobile, what is it that's sustainable there?
Welcome to the Museum of African American History's Race in the Public Dialogue in partnership with the GBH Forum Network. We'll get started in a minute.
I am called Onesimus. I am told it means useful, but my real name is lost. Though my body was brought here and then bought here in Boston, my mind and spirit were never of this place. They were filled with Africa. Onesimus, Cotton Mather asks, have you ever had the smallpox? Well, yes and no. You see, my people have the knowledge of how to take the juice from the sore of the sickness and scratch it into the skin, and in this way, make a shield.
I do my work because I love my work. We have taken a lot of the knowledge that we have gained over the last 6 years and applied it to a fairly revolutionary vaccine platform in collaboration with Moderna.
I'm Dr. Christina Greer, your host for this program. Onesimus, his name was lost to history. We're just beginning to learn his role and his impact.
Cotton Mather. Yes, the Puritan minister who laid the groundwork for the Salem witch trials. To that same Cotton Mather, I was given as a gift for his use by his Christian congregation. So you can understand why I would have no use for their God, a God who would protect neither me nor their white bodies from disease. Mather couldn't imagine that what I told him could be true. But as smallpox raged through Boston, he began noticing that neither I nor the others, Africans, were getting sick. So eventually he told the city doctors what I'd told him. They wouldn't even consider that I, an unchristianized African born of sin, could be a sign of grace. That the buked and scorned could serve as a savior and maybe make a miracle. One after another, these very learnt men of Boston rejected the procedure and argued, we will never trust the word of a slave. Only one, a Dr. Zabdiel Boylston, would try it. And when it worked on white bodies, did Mather thank me? No. He thanked his God and then cast me out. And even the name he gave me, Onesimus, was written out of American history. Until now. Onesimus. I am told it means useful.
The vaccine teaches the body how to fend off a virus because it teaches the body how to look for the virus. By basically just showing the body the spike protein of the virus, the body then says, oh, we've seen this protein before. Let's go fight against it. That's how it works.
While Onesimus was initially written out of history, Dr. Kizzmekia Corbett is making history today. The COVID-19 pandemic is the most devastating health issue of this century. It has had a disproportionate impact on African Americans in particular and other marginalized populations. This virus highlights racism as the root of America's public health crisis. Now, to begin a discussion about the effectiveness and availability of these new vaccines, especially for African Americans and other people of color, I'd like to introduce two local doctors who can share their insights. Joining us this evening is Dr. Bisola Ojikutu, an infectious disease specialist and health equity researcher. She has dedicated her career to overcoming racial and ethnic disparities while eradicating the impact of structural racism on infectious diseases such as COVID-19. Dr. Ojikutu is an associate physician with the Division of Global Health Equity at Brigham and Women's Hospital. Welcome, Dr. Ojikutu. And Dr. Paulette Chandler. Thank you. And Dr. Paulette Chandler serves as the lead for community engagement and education for the COVID-19 Moderna vaccine trials at Brigham and Women's Hospital. She has worked extensively within the African American community, providing vaccination education. She's also a primary care physician in the Division of General Internal Medicine at the Brigham and Women's Hospital. Welcome, Dr. Chandler.
Thank you.
So COVID-19 underscores the need to make sure all people are considered in the trials for the development of the vaccine. And Dr. Chandler, I want to direct this first question to you. Trust is a major part of making sure the vaccine trials were safe for everyone. Can you speak a bit more about the trials?
So we were involved in recruiting individuals for the Moderna trial in the Boston area, and trust was a big factor. Of course, anytime you decide to participate in a vaccine trial, novel mechanism of development, and also in the backdrop of a lot of racial disturbances in the US, it's a challenging setting to recruit individuals for this type of trial, as well as to engage them to be ambassadors. So we partnered with our community health centers. They were key in terms of helping us educate the community about the trial, as well as forming a collaborative network where they were willing to be ambassadors for us. We also partner with faith-based organizations, our churches and other community networks. So our pastors were very involved in helping to educate their congregations, and our community centers such as Sportsman Tennis and Enrichment Center, which is a center that provides free tennis education classes, as well as after-school programming. So these various networks allowed us to effectively educate the community, as well as to be successful in recruiting a diverse number of participants for the trial. And so,
go ahead, please.
So in conclusion, when we look at the diversity of the trial over a 3-month period, which was our recruitment period, we were able to recruit about 10% African American, 20% Latinx, and 25% elderly. And that informed the interpretation of the results. Since we had a wide background of various individuals involved in the trial, these results are generalizable to various race and ethnicities, as well as age groups, as well as individuals with underlying health issues that might make them more susceptible to developing infection, as well as complications from the infection.
So Dr. Chandler, I want to stick with you because so many people are worried about the vaccine. And so what work needs to be done to make sure people of color actually take these vaccines when they're available? And what's your response to their concerns?
Okay, so a variety of concerns, of course, are prevalent in the community about the vaccine. 1, is it safe? 2, does it work? 3, will there be long-term side effects? And 4, is it okay for me to wait while I watch how it affects other people? So we know that we need trusted messengers to interact with individuals. So for example, at our hospital, we're developing a trusted messenger program, but we've also encouraged our peers, those who've already received the vaccine, to share their experiences. So we have a program called #MyWay. And one thing we notice is that when individuals talk about the vaccine with their peers, if their peers already received it, they are more likely to think, okay, well, I saw that person, they got it, nothing happened to them, then it will be okay for me. The other aspect, though, are our young adults. They often are more open. Some are more open to receiving a vaccine. So they can be an influential member in their community in terms of letting their elders know that this is an important step for you to take. Whereas for others, I see the elderly, they're being more eager to step up. For example, my mother's group, she's in their 80s, and they're all saying, oh, when I want to get that vaccine. And so it's influencing the younger to think, okay, well, maybe I can pull back on my reservations and concerns about safety. If grandma took it, I can take it.
Right. Well, it seems like the elderly are the new teenagers. They're the ones that want to be out and about. So we're trying to keep them in and keep them educated as well. And Dr. Ojikutu, I want to bring you in. This question is for both of you, but I'll start with you. We must say the name of Dr. Susan Moore, a doctor of internal medicine, a graduate of University of Michigan School of Medicine, who documented the way she tried to advocate for herself as a patient before succumbing to COVID-19. So if someone as knowledgeable as Dr. Moore faced so many challenges in securing her care, what can people do to advocate for themselves and also for their loved ones?
So I think that this is a really important question. Dr. Moore's life and legacy in this history tells us a lot about our world. But first of all, what I would say is that no one should have to advocate for themselves or for their loved ones when they're sick, okay? We need to understand that high quality, compassionate, structurally competent care that considers the fact that, health is really dependent on addressing structural racism and inequity and the economics of the situation and the social context, that should be the norm for the care that we receive. And I do not believe that the onus can be on the people to advocate. The onus needs to be on the system to change. Health it's a fundamental right. So I would shift the focus of the question. I would really say that we really need to look at our systems. I think, unfortunately, even when you look at what's in the news now, still about Dr. Moore, a lot of people are denying the structural racism or, any aspect of systemic inequity had anything to do with her care, which I think is absolutely ridiculous. We, in our research group, we just finished a nationally representative survey where we found that basically most Black people were pretty, outspoken about the fact that they believe that Black people are treated differently within the healthcare system. They receive different care from healthcare providers. So it's clear that something's broken and it needs to be fixed by the system, not by the patients per se.
Dr. Chandler, did you want to build on what Dr. Ojikutu said about some of the structures within the institutions that need to change?
I agree. There are structures that need to change, even in terms of insurance structure. I mean, patients, they want to get care at certain facilities and they don't have access because of the type of insurance they have. And then even once they hit systems, they feel that their pain may be ignored or their symptoms may be ignored. And we know we have data showing that when patients receive care from physicians that look like them, they feel that their symptoms and issues are more completely addressed. And so we do have to address these structural systems that are in place, even where hospitals are located and the type of services that they provide, preferentially to one neighborhood and ignoring another neighborhood.
Thank you. So Dr. Ojikutu, what does equity look like for this rollout? And what are some of the challenges? You begin to touch upon some of the structural difficulties. What are the real challenges with this rollout?
So I think there are lots of challenges, but what I would say is that equity doesn't look like vaccinating a certain number of people within a certain time frame. Okay, that's not equity. That's efficiency, maybe. That's going very quickly, and it's what we need to do in the setting of an emergency, but it's not a measurement of equity. And I do think that equity and efficiency can go hand in hand, though. There are probably four immediate steps, like sort of the urgent things that need to happen. One, we need to prioritize access in neighborhoods that are, most highly impacted. So geographic spaces that have been where the people in those spaces have been most highly impacted by COVID-19. Two, you can't just have access points within those neighborhoods or mobile or whatever it is you're doing, drive through or whatever. the vaccine supply that goes to those access points needs to be for those people in those communities, and that's not happening routinely. Number three, what in terms of actually accessing appointments, that needs to be seamless. And I know here in Massachusetts we're doing work with telephones as opposed to, or work in conjunction with online stuff, because the reality is that more than 21 million people in this country don't have access to high-speed internet. So having that as the way to go doesn't make any sense, especially when you have elderly people who may not be as tech savvy, people who are, don't have English as their first language, whatever it is, it needs to be seamless. It needs to be easy. And then lastly, I would say we need the data. I'm not just saying that as a researcher. What I'm saying is you can't measure change over time. You can't say that something has been equitable unless you know what it was at the very beginning. So we need to not only know race and ethnicity and age, we need to know other things about people. We need to know their language. We need to know their country of origin. We have a very diverse population across this country. We need to know sexual orientation and gender identity, because you don't know if something was inequitable until you measured it. So that needs to be inherent to the process. So I think those four sort of immediate steps are the kinds of things that we need to be doing.
Absolutely. I mean, here in New York, we're finding that, suburbanites are coming into New York City in sort of very highly populated Black and Latinx areas and getting the vaccine. We're still scratching our heads as to why is it that people who want it can't get it. And so this last question is for both of you. Dr. Chandler, I'll start with you. This pandemic has revealed so many shortcomings in our healthcare system. And you sort of mentioned that when you started talking about insurance, but how do we shift the narrative moving forward? What do we need to be doing long term?
So there are multiple strategies. One, we need to make sure that we are addressing the underlying determinants, what we call determinants of health, that put these communities at increased risk. Housing, we know congregate housing density was a big risk factor. We know that employment for frontline workers were at increased risk. Address low wage paying jobs, because some people, they continue to be exposed even though they knew they were at risk. Or improve the workforce development. So thinking about how do we get more people of color in the pipeline into healthcare, so that there's a framework where multiple voices are involved in shaping policies. And then the last one is improving housing, giving access to better housing, access to better food, to address underlying health conditions that develop when you have poor housing, poor food conditions, and poor healthcare. So having more people in the pipeline that look like people that they're serving will improve quality of care.
Dr. Ojikutu, did you want to add something about what we need to be doing moving forward long term?
Sure. No, I agree with everything that Dr. Chandler has mentioned. I would add a couple things. Just, first and foremost, we need to acknowledge that structural racism is a crisis, and we haven't done that uniformly. There are certainly some states that have, and some, obviously maybe more progressive individuals who have, but certainly that's a proportion, a percentage of what we need to do. But, in addition to that, we need to look at the community and look at our relationship to communities. The reason why communities are, sort of outside the process, they're marginalized, they're not necessarily engaged in the healthcare system, is because there's been disinvestment over decades. Okay, so what we need to do is reinvest, build capacity. Even while we're in this emergency phase, we need to be thinking long term. What can we do with these, like, if we're talking about drive-through vaccination, pop-up, mobile, what is it that's sustainable there? What type of workforce that Dr. Chandler mentioned could be built that could be long-standing in those communities? That while we're developing these sort of emergency sort of strategies, do we want it all to just end because we feel like we've addressed COVID-19? No, we want to have used this experience to shift the relationship between Black communities, brown communities, and these systems. I think that's really the point. We want the history to change. And I'm hoping that somebody will have that type of vision, because I do think that takes a visionary sort of leadership.
Well, I feel so much better knowing that you two were on the case. I will say that. And I know that our viewers definitely feel much better knowing that we have doctors like Dr. Chandler and Dr. Ojikutu with us. And thank you all so much. Thank you both for being with us this evening.
Thank you.
there's always more information about these hidden figures and more on the Museum of African American History website. Now, race did not exist in the English language until 1508. That's according to the groundbreaking Pulitzer Prize nominated work by Dr. Michael Bird and Dr. Linda Clayton. Their two-part volumes of The American Health Dilemma describe how race was used to organize society through a social, religious, and scientific construct. The perception of race was so deeply embedded that it was nothing to look at Black people as the others who felt no pain and whose bodies could be experimented on with no regret or remorse. With me now is Ododuri Okwandu, a presidential scholar and doctoral candidate in the Department of History of Science at Harvard University. Her current work examines science and medicine's relationship to power and its impact on underrepresented and marginalized populations with a focus on the Black community. Let us start right in. Welcome.
Hi,
How are you?
doing so well. How are you?
Good, thank you. So I want to start with this first question. The perception of race was so deeply embedded that it was nothing to look at Black people as the others who felt no pain. So what examples from your research support this premise?
Yeah, so the notion that Black people feel less pain dates back to as early as the 18th and 19th centuries, when there was a belief that nervous systems were essentially racialized, and there was this idea that Black people had thicker nerves and therefore they had less pain. And I think where this was most evident was in experimentation, particularly in the realm of surgery. So if we're thinking about the development of obstetrics and gynecology, for example, a lot of that wisdom was produced off of the bodies of enslaved Black women. The C-section was pioneered by a French man named Francois Menis Prevost, who repeatedly did these experimentations on Black women's bodies. And we often hear about James Marion Sims, who is called the father of gynecology in the United States. And he pioneered a treatment for vaginal fistula and pioneered the speculum, which is a common tool for gynecological procedures today. But he conducted a series of experiments on enslaved women without any sort of anesthesia, despite the fact that it was experimental but still used during this time. I think another example that is useful to think about is how, in terms of sterilization cases that happened in the early 20th century in the 60s, which was kind of this idea that, there's an intentional subjugation of pain upon Black bodies that's happening during this period. And we can't not mention Tuskegee syphilis study, where we had, untreated syphilis for these populations because this idea that this need for medical knowledge without any true regard for the people that are being impacted. So it's a long trajectory.
I think it's fascinating just because also, in New York, we just removed a statue of Dr. Sims last year, I believe it was, maybe a year and a half ago. And so there was still a monument to him. And then we think about the women who were sterilized just last year at the border. So these practices are still continuing. And obviously the effects of the syphilis experiment in Tuskegee have real world effects of people who were distrusting the vaccine in 2021. So these things stay with us. So how should we currently think about these fathers of science whose research was fostered by their racist views of the time?
Right. I think something I often think about or I observe is people have difficulty recognizing that there can be two sides of something. Something can have a very positive impact on society, whether that be medical knowledge or scientific contributions, but oftentimes it can have a very dirty history, as we have seen. And just because something works, that doesn't mean that it's beyond critique. And so I think it's critical that we need to kind of parse out this impulse to view science and medicine as these objective or apolitical or neutral spheres, when in reality, it's being carried out by real people who operate in a real social world that are impacted by certain ideologies. And if we're thinking about the impact of science and medicine on the Black community, that ideology is race, and a system that views Black people as inferior or less than. And so we have to think critically about, I think we need to be willing to hold both of these truths side by side, lest we make the mistake of continuing the same mistakes that have been made in the past.
Absolutely. And then I want to sort of ask you, what changes have been put in place to remedy this situation, and have they been effective?
Yeah, so I think the most critical period for human research actually happened in the 1960s through a doctor named Henry K. Beecher, who worked at Harvard Medical School. And he basically, I mean, and that's not to say he was the person who, revealed, it was the first person they listened to. And he happened to be a white man. So that even a larger question about, whose voices matter. And when do we pay attention to abuses? But he exposed that a lot of the individuals that were being subjected to unethical experimentation were the poor, were the physically or mentally handicapped, were the elderly, were those who were incarcerated. And more often than not, that disproportionately fell onto Black and brown bodies. And so his findings actually led Congress to establish a national commission to explore medical ethics, and is largely the basis for the protocols that we kind of see today. And so, while I definitely think there's been huge advances and huge improvements in terms of human research protocols, I still think that there's issues on a global scale. When we think about the fact that, a lot of pharmaceutical companies, for example, might be traveling to developing countries such as India, or a case even happened in Nigeria, where they're giving experimental medications and treatments to vulnerable populations. And so while it might not be as explicit in the US, we still need to think about how this logic of, taking advantage of more vulnerable populations still perpetuates even in our own moment.
Indeed. And I just want to encourage our audience to please put in questions in the chat if you have any for our various doctors that are going to come through, but also for Udodori Okwanju as we're wrapping up here. You mentioned something about sort of some of the institutional mechanisms put in place to make sure this doesn't happen again. Can you talk to us a little bit more about the institutional review boards for human research? We call them, the IRB. When I'm doing surveys, I go through the IRB, and usually for social scientists, it's a headache. I'm not touching anyone. I just want to ask them some questions about their lives. But in the medical profession, the Institutional Review Board really does help us sort of keep human research contained in an ethical way, hopefully so. Can you tell our audience a little bit more about that?
Yeah, I'm definitely no expert on IRBs, but I definitely know that there's a big emphasis on peer review. There's a greater emphasis on, thinking about who are these drugs that we're testing them on as a representative of the larger population. And are we making sure that it is, with equitably and, with in mind when we're doing these sorts of things. And so I think it allows us to be definitely more trustful of new technologies or vaccines, just as the COVID vaccine that's coming out today. But I think even if we do have these, equity embedded in these IRB boards, we still have to think about what's going on with distribution, which I think was really highlighted in these in the earlier segment, and how that can still be a larger problem, even if we have, these review boards in a different presence in terms of these trials.
Yeah, I want to sort of get you to sort of tussle that out just for our audience listeners. So is that part of the reason why these vaccines can be trusted, because of these review boards and the presence of different types of people who participated in the trials?
Yeah, I definitely think that's part of it. And that is one way that we can have more trust in this vaccine. I think there's been a lot of worry that, it's been developed so quickly, or, but we have to keep in mind that research in coronaviruses have been happening for decades, largely in response to these protocols that have been embedded. And the ways in which vaccines and other drugs can be produced so quickly is if it receives funding. And due to the global impact of this virus on the larger global community, funding was thrown into COVID vaccine development and distribution and research. And so it was unprecedented. And so, yes, it was quick and speedy, but it is because there was a larger global need. And I think that in itself, one, it requires more understanding of how larger research protocols happen. But I think we have to, in this case, really, kind of trust the science in these cases, and recognize that people are attempting to work for the greater good.
Indeed. And I think, I've heard that phrase so often, trust the science. My sister's an MD and trying to do vaccine awareness as well. And that seems to be a refrain to help people contextualize. Yes, this seems to have come up suddenly in our world, but not necessarily in the medical community that's really dedicated, all hands on deck for quite some time. I've got a last question for you from Faith in our audience. She says, are there any instances when a Black or brown leader raised these issues and institutions like Congress have reacted, or even in the scientific community?
Yeah, there's one too many issues. I mean, even if we're thinking about when Henry K. Beecher, the example I discussed earlier in the 1960s, when there was a discussion on abuses with human experimentation, that was in part largely driven by members of the Black Caucus at Congress who became aware of attempts to biologize violence. And that would disproportionately impact Black community members. And so I think that's one of the problems that we see with knowledge production, is that there's so many invisible figures. There's so many Black activists and Black voices that are undermined or ignored until, oftentimes people from the dominant population say something. And so there's countless examples of Black people speaking out against these sort of things, but it's just when they're taken seriously is very situational.
Well, I want to thank you so much for bringing in this idea of descriptive representation in Congress so we can get substantive representation in the issues and policies we need. I thank you so much for your research. Thank you to Odudori Okwandu for joining us this evening.
Thank you.
The community health centers have become the place to treat the marginalized with a holistic response. It's the place where people of color can get care from the doctors they trust and in settings that are close to where they live. The health centers provide comfort with the language that is spoken and the respect that is given towards culture. With me now are Dr. Yvette Cozier, the Assistant Dean of Diversity, Equity, and Inclusion and Justice at the Boston University School of Public Health. Her overall research has been on the role of racism and health in the neighborhoods. Dr. Cozier is also an investigator of the Black Women's Health Study for the Boston University School of Medicine. Welcome, Dr. Cozier.
Thank you for having me.
Also joining us is Michael Curry, CEO and President of the Mass League of Community Health Centers. The League represents low-income Massachusetts residents from diverse backgrounds, serving over 1 million patients throughout the state. Both Michael Curry and Dr. Cozier are on the Massachusetts Department of Public Health's COVID-19 Health Equity Advisory Group. Welcome to you both. Thank you so much for being here.
Thank you.
Thank you, Dr. Gregg. Good to be here.
So, Michael Curry, I want to start with you. What is the role of the community health centers in the vaccine rollout right now?
Yeah, so, it's funny, Dr. Gregg, I always start with how we got here. And I think that's a critical part. And credit to the other doctors that you had on, really giving us the history and the context. So know that during the modern civil rights movement, when people were trying to integrate lunch counters and desegregate our schools and get a quality education for our kids, there was also a battle waging to give us equity in healthcare, to give us access to quality healthcare. And that was led by Dr. John Hatch, Jack Geiger, Count Gibson, some names that people may not know, but you need to know. Doctors, Black doctors across the country, like Dr. Smith in Mississippi, were leading the charge. We just lost Jack Geiger, the father of the community health center movement, just last month. I say that to say, what is the role? They created health centers in 1965 for a reason. This was about providing health care when people walked into those buildings, but it was also about empowering communities. But it was also about dealing with those social determinants of health that the doctors talked about earlier, the poor water, the infrastructure, the environmental hazards. So we're now here at this moment many years later, and we're faced with a pandemic. And I call this, Dr. Greer, our national Katrina. Just like Katrina, we should have known that the people who would be most likely to die and be infected and be hospitalized would be those who are housing insecure and essential workers, frontline staff, first aid and first responders. We should know that people didn't have supplies to stock up on water and food because they were poor. And guess what? We should have known that many of them would be Black and brown and would be hospitalized and die at higher rates. So none of this should have been a surprise. And there have been many activists telling us this for decades. That being said, health centers are trying to respond. We are the canaries in the coal mine. We treat those communities, immigrant communities. Some of our health centers treat patients, populations that speak up to 30, 40 languages within a community. That's pretty amazing when you think about that. The diversity of the neighborhoods, they're most often people of color, they're poor, they're dealing with DACA and they're dealing with public charge and all of these policies that are having a chilling effect on people getting care. So in this moment around vaccines, we have to figure out how to build up our systems. We're often underpaid, structurally not supported in the way we need to. But right now, people are trying to figure out how to lean in and support health centers so they can ramp up and be able to provide the vaccinations that are necessary.
Thank you. And Dr. Cozier, this question comes from Denise. Do you feel the focus and attention on health inequities spotlighted by COVID can be sustained after the vaccines kick in?
Well, it's certainly my hope that it will. One of the things that COVID has done is really expose all of those fault lines that Mr. Curry just mentioned and that have been mentioned in previous segments. It's very clear the communities that were at risk and remain at risk, and the reasons, the mechanisms through which risk happens. We can take this opportunity to not ignore these things, not cover them over, but make lasting change. I think in a previous segment, it was said, if we're setting up these testing facilities, these drive-through facilities, these don't have to go away when COVID starts to recede. We can begin, continue to deliver care in these ways that make it easier for people to come in and to be treated for various things. So the thing about equity is that it has to be intentional. And that is the thing that we must push for, that we continue to hold the light up and not conflate equity with equality with efficiency. Understand equity means the distribution according to the need, and make sure that we focus on that and we remain intentional.
Thank you. And Mr. Curry, I want to ask, where are we with the rollout of the vaccines in Massachusetts right now?
Yeah, I think, and I've heard you speak about the failures in New York. And I think we're seeing the failures across the country. The reality is that we weren't prepared for this moment. I often say from a federal perspective, and I use this word intentionally, we defunded our pandemic response.
Yes.
So when people talk about defunding, the Trump administration and previous administrations did not put the focus into pandemics, although we knew this moment was coming. That being said, even state governments, our local public health departments are not equipped, do not have the staffing, the supports that they need, our local public health infrastructure. Many times you'll have a health center in a community that when the crisis kicked in and testing was necessary, public health departments had to turn to a local community health center that have a set number of patients that they treat on an annual basis and said, no, we need you to treat everyone in the community. And that's unreasonable, though, they're open to anyone who walks through their doors. We should have been prepared for this moment. I think it's interesting where you will see some states that are vaccinating at a higher rate, but I'll argue when the numbers play out, it won't be equitable. They're just trying to get doses or shots in arms, but they're not prioritizing communities. Here in Massachusetts, we did a plan that I think was an attempt at equity, but then there's what I call a scrum. Everybody's just trying to open up and get anyone shots that they can. And we lose in that scenario because we know that we're not as savvy. We may not have the Wi-Fi access to the broadband or the smartphone, particularly for our seniors over 75. We're at a competitive disadvantage to get our shot. Ayanna Pressley, our congresswoman, who people across the country know and revere, has a quote. She says, people closest to the pain should be closest to the power. I have a spin on that. People closest to the disease should be closest to the vaccine. And that's not happening.
Wow. Yeah. And sadly, we're seeing it in states all across the nation. Dr. Crozier, what changes are needed then to guarantee that equity is a consideration versus an afterthought?
Yeah, so just following up on what Mr. Curry just said was, the way the vaccine is rolled out, we saw this with testing as well. Testing was most plentiful and accessible in the communities that had the lowest risk. We have not pivoted quickly from testing to vaccine, so it makes sense that we continue to be in this mess, if you will. Again, we need to take this moment. All hands are on deck, and we need to continue to hold these task forces, to have these advisory committees. They don't need to go away once we start to get a handle on COVID-19. We have to stay in place, and we have to continue to address those areas of inequity that are so exposed right now. So this is we have what we need in terms of sounding the alarm and planning for the next time. And
Right.
and and this goes beyond health. I mean, we've certainly seen how this health crisis has rippled into an economic crisis, into an educational crisis. We can pull our same resources together and our same minds together and continue to work together to try to bridge those gaps.
Indeed. I mean, this crisis has just exposed this nation and all of our Achilles heels throughout all of our various policy points. I want to encourage our audience to submit questions, please, for Mr. Curry and Dr. Crozier, if you have any more. This one is for Katie, and I'm going to ask it to both of you. Mr. Curry, if you would start with it, to what extent will the record enrollment of people of color in the COVID-19 vaccine trials drive diversity in future clinical and pharma trials involving various other diseases?
Yeah, I think, people ask me all the time, is this a moment or a movement? And I think the answer is yet to be told, right? So whether you're talking about George Floyd and our criminal justice system or our healthcare system, I think like the other doctors on the line today, and I've been blessed and fortunate to be on calls with many of them talking about these issues. I've never seen, and I've been a civil rights activist since my college days, I've never seen a unified focus on equity issues and racial justice ever in my lifetime. What does that mean? That means that this could be a movement, but we're going to have to demand that this attention stays there. We have a challenge right now that ultimately these working groups that we serve on, these studies that are underway, I serve on at least 7 health equity task force that are looking at the underlying issues as to how we got here. Why do we have higher rates of asthma, diabetes, heart disease, cancer, almost every disease you can name? Black and brown people are dying, living 5, 10, 15 years less. It's always been unacceptable. I can't help but to think about one of the slides that you showed tonight was Rebecca Lee Crumpler, which I don't think she gets enough attention. Yeah. First African-American woman to become a doctor of medicine in the US in 1964. Just context, a year before Civil War ended and a year before the 13th Amendment was passed in Congress and ratified. She had a quote, she said, "They seem to forget there is a cause for every ailment and that it may be in their power to remove it." We know that none of these diseases that kill us at higher rates, that take us gone too soon, are not addressable in our society. Now, that is the challenge, I think, before us. We have to demand that. I argue that if we understood the death rates from these diseases unnecessarily, compared to the knee that was on George Floyd's neck, and we marched for that, we demanded justice for that. But if we knew the higher rates of death and sickness from these diseases, we would have been in the streets a long time ago.
Dr. Crozier?
Yeah, what I would say regarding the things that we can do, little by little, we've seen institutions like like NIH, National Institutions of Health, within grant proposals requiring that investigators submitting applications for funding describe who their study population is and start to make a case for why the study population is homogeneous and does not have any diversity. Institutional review boards, which was discussed in an earlier segment, is also just beginning to require investigators at their institutions to make a case for who they're enrolling, and again, why there might be a homogeneous study population, and what can be done in terms of having greater diversity within biomedical research. So this is happening on a slower basis, but it's definitely over the last 25 years that I've been in research, starting from it never being considered to at least being considered, is a slow step, but it is a step. And so we need to continue to build upon that to bring about more diversity.
And Dr. Greer, just a quick add on that too. So the Harvard Chan School here in Boston, I worked with them just over the last few months, and they've convened a group of community leaders, community activists that will review these clinical trials, and they come before this board. So I think there's a movement across the country to make sure that there's transparency, there's accountability, and there's community involvement in the review of them. And it's not just about reviewing them in terms of their inclusion. It's also about lifting up the research of Black and Brown researchers who don't get funded, who don't get attention, who also need that support as well. So credit to the Harvard Chan School and the work that Karen Emmons and the group there are doing. It's a model for the rest of the country.
Well, I want to stick with you, Mr. Curry, because this is a question in from Helene. And so she says, and this is kind of inside baseball for some of our viewers, but it says, you and Liz Walker probably other people of color were on the governor's coronavirus task force. Don't you think that you, Liz Walker, and others should have known that the state's computer map sign-up, which was so disastrous, would also fall inequitably on people of color? And so I guess this goes back to the computer versus phone conversation that we were having in earlier panels.
So I think there's a misperception as what our role was on the governor's COVID-19 vaccine working group. Every state, I believe, had to set up one of these groups. And the group purpose was prioritization. So that's why healthcare workers were first in phase one, right? The conversation. It's why Liz Walker, myself, Dr. Wanda McClain advocated that we include incarcerated, because we understand the new Jim Crow and the mass incarceration of our people. It's why we advocated that phase one include homeless shelters, because way too many of our people are in homeless shelters, or that we go with COVID-facing healthcare workers and then non-COVID-facing healthcare workers. It's why we advocated for comorbidities in phase two, and that 65 plus include those comorbidities as we open up to broader populations. So to that question, we had no part in the operationalizing of that prioritization. That is the work of the state to do that, Department of Public Health, and here in Massachusetts, the Command Center. And as Dr. Greer knows, the local public health officials in New York. So I did not have any part in the system. In fact, I'm equally as frustrated that people can't get an appointment and that people are driving into Roxbury, Dorchester, Mattapan, for those who don't know our Black communities here, and getting their shot, why Black and Brown folks are not. And one last thing I'll say to that. I use the legal term, which is first right of refusal. I don't care if a Black mother in Roxbury is hesitant and doesn't trust the vaccine, and we got to work to get her to trust it and understand the science. She should have the first right of refusal to at least say no. And then when she's ready, we need to put her in line because she's most at risk. So to the point about the failures in the system, we're equally as frustrated. And I speak for me and Liz Walker as well.
And so this last, thank you, Mr. Curry. And thank you, Helene, for asking that question. Dr. Crozier, this last one is for you, somewhat of a follow-up. Do you all think essential workers in service industries should have been included in phase one of the rollout? Would this have improved access in marginalized communities?
Well, certainly, and to Michael's frustration, we are also on the advisory board, and these are things that we have certainly pushed for. And being advisors is different, again, than being those who are, put with the operationalizing. Yes, one of the frustrations that I've had is we keep going back and forth between this, is it an economic thing, is it a health thing? And we cannot have a healthy economy if we don't have healthy workforce. I've said that from the very beginning. That is like the creed of an epidemiologist, understanding how it all works together. And so if we wanted our economy to get running, we needed to get the people that we now dub essential, although we don't necessarily pay them, but we dub them as essential to be the workforce that is at lower risk, or we've mitigated their risk. So this continues to, again, we see these things, but we we work in a system of government in which we have to keep pushing our leaders to do the right thing.
And
Well, I
Dr.
can't
Ray-
thank you all enough. I'm so sorry we're out of time, but hopefully folks will continue to talk in the chat, and maybe Mr. Curry, if you stick around, you'll be able to answer some questions in the chat. So I want to thank Michael Curry and Dr. Cozier for joining us this evening. So as we move into the future, we have to believe there is hope and now best practices to remove implicit bias in the healthcare system. Our next guests are members of Massachusetts General Hospital Center for Diversity Inclusion. With me are Lucy Obu-Wobodo, is a third-year resident at Mass General Hospital and McLean Psychiatry Program. Josh Boodoo, a current neuro-oncology fellow at Mass General Hospital and Dana-Farber. Dr. Natalie Green, an orthopedic surgery resident who was a key player in the new clinical service of native Spanish-speaking physicians working with COVID patients. And also joining us is Dr. Alden Landry, Assistant Dean for the Office for Diversity, Inclusion, and Community Partnership at Harvard Medical School. He's also married to a jumbo, so he's my favorite because of the Tufts University connection. I want to welcome all of you for joining us this evening. Thank you so much. Dr. Obu-Wobodo, I want to start with you. Racism is such an intrinsic part of our culture. How do we begin to change the culture of healthcare so there are better outcomes for all patients? Can you give us some examples?
Yeah, thank you so much, Dr. Greer, for that very important question. I think it's really important to highlight what has already been mentioned by other panelists earlier. We know that structural racism is deeply embedded in our healthcare systems, and these include policies, institutional practices, cultural representations that work in really various reinforcing ways to perpetuate racial health inequity. And to really begin to address these issues, I think the healthcare profession as a whole have to really acknowledge our historical and our current roles in perpetuating these inequities. There's no way to fix things until we actually acknowledge that they exist. And this includes embracing a truth and reconciliation strategy and acknowledging that we as healthcare professionals, although we are very, in many different ways, very highly altruistic, we exist in structural systems that has to be dismantled before real change can happen. We know that if we eliminate interpersonal discrimination, we will still have structural racism in healthcare because of structural institutions in place and systemic racism that can keep these issues going. It's not just about well-meaning people, it's about dismantling the system that has been in place, like other panelists has already mentioned. And to do that, we also started looking at how do we self-critique and self-evaluate individually and as a system, looking at the ways in which our policies, in which our practices continue these issues. And we also truly have to look at the workforce diversity. We know that healthcare is not representative of the country at large. We have a very multi-ethnic, very diverse country, but our healthcare workforce does not reflect that. And to truly make a change in bridging health disparities, we have to look at the ways that we can actually change the workforce in healthcare. And that's not just about getting numbers of people making a quorum, but actually amplifying and raising diverse experiences, diverse background, diverse people of color, and different background in general in the healthcare system so that we can then begin to reflect our nations. We know that when patients have physicians or healthcare providers that look like them, as already mentioned before, we have better health outcome, and we have to be very intentional in how we do that.
So thank you for that. And Dr. Landry, Dr. Obu-Wobodo started this conversation, but your focus historically has been on workforce diversity. So what is working and what still needs to be done?
Well, thank you for the question. I guess maybe I'll start just a little bit further upstream and just to say where we're at with the numbers. As we typically talk about workforce diversity, we truly emphasize on who are underrepresented in medicine, which are Black, Latinos, and Native Americans. And although we make up about 32% of our nation's population, we only account for about 13% of our practicing physicians. And so I think that's part of the problem. But then you tease out the problem a little bit more and look more into the details, specifically related to Black men. There are more Black men accepted to medical school in 1978 than there were in 2014. Now, that's despite adding medical schools, adding size, increasing the sizes of those institutions, and expanding opportunities for careers in the health professions. And then lastly, one other point I'd like to highlight, for all the medical institutions, on average, we sit with about 2 Black male full professor physicians at each medical school across the country, and 1 Black female full professor at these same medical schools across the country. So we have not only lack of representation of individuals from underrepresented backgrounds in medical schools, but then also who are practicing in our clinics, practicing in our hospitals, and then lastly, who are achieving the highest ranks in our profession. Now, the question is, how do we fix this? And a lot of the work that I do and a lot of the work that has really been impactful, what we do here at Harvard Medical School and across the country, is building pipeline programs, allowing individuals to have opportunities for entry and exit as they pursue a career in the health professions. Now, I'm a product of those pipeline programs. I participated in them throughout the longevity of my career, and I still think that those pipeline programs are going to be beneficial in me moving forward. But we need to make sure that the funding is available, that we're allowing students opportunities to pursue a career in health professions, and we're also not discouraging them when a student shows promise and they have an interest in the sciences. We want to encourage those individuals to go on and pursue careers in the health professions.
Right. And it's so interesting how some of these calcified problems are across so many different disciplines. You could be at a political science conference right now and we're literally saying the same things. Dr. Boodoo, I want to bring you in. What steps can be taken to increase the trust levels between patients and doctors in order to empower those patients to have the tools to engage in that relationship?
Yeah, thank you for the question. I think really at the heart of it, we really have to go back to the basics and focus on communication, honesty, and transparency. Trust starts from the ground up. As on the other side of the equation, as a family member and as a patient, I've had the unfortunate experience of being talked down to, information being withheld, not feeling that appropriate care was being given, or kind of just being given the runaround when asking questions. But once I tell them that I'm in the medical field and I'm a physician, the experience changed immediately. We shouldn't have to be part of the system or be in the system to get equitable or equal care. In terms of communication, we need to really speak in language that is appropriate, culturally competent, easily digestible, and devoid of medical jargon. Using an interpreter, especially if your patient is not comfortable in English, is always a must. And we have to also make sure to include family members, key decision makers, as well as friends. Communication is also not just verbal, your body language, how much time you spend with the patient, even just sitting down and looking them straight in the eyes is a big part of it. I shouldn't really have to say this, but being honest and transparent with your patients is one of the things that's really the most utmost and most important things. We should never withhold information. We should never be in the position of telling patients what to do, but sitting down and discussing and engaging with them with shared decision-making. I think most of all, we need to realize that trust is mutual and patients trust doctors who trust them.
Right, right. Thank you. And Dr. Green, what role does empathy play when it comes to looking at patients as more than the other? As Dr. Boodoo just sort of mentioned, you have this amazing initiative with COVID-19 patients and their families.
Mm-hmm.
So how do we fill this need?
Absolutely. Thank you so much for that question. I think tracing back a little bit to what you discussed, it's easier a lot of times, and a lot of us as doctors are taught to sympathize with our patients, but empathy goes beyond that. And we all understand that it's easier to have empathy when you have a shared experience. So as someone who identifies as Latinx, for me, the shared experience was sharing a language, a culture. And when I started noticing 60% of our patients last March, April, May were Spanish speaking, it became more natural to me to want to empathize with people that look like my family members. And I sympathize with Dr. Boodoo, what he mentioned, like family members many times not being offered interpretation, not being offered culturally competent care. I have thought about this question because you don't necessarily have to speak a language or share an experience to care about the patients and for patients to feel the care and the warmth that is necessary many times in our interactions. I truly believe that I've thought about this in 3 approaches. One is our unified voice. I think COVID provided an experience to Latino doctors at MGH to come together and become a unified voice, create this organization where we deployed an entire cadre of doctors who spoke Spanish and started caring for the patients. I think the other area that we can talk about is, aside from our unified voices, sharing our story and truly being empowered to share our story and empowering our patients to find the value in their stories. And through the sharing of our stories and becoming parts of the community and the healthcare system, I believe our peers are learning more about our experiences, are learning to empathize because they see one of their own that have these experiences, that have lived these things. And in orthopedics, just 1.9% of the orthopedic force is Latinos, and female Latinos is less than 1%. So having me sitting in these conversations, I believe has changed a lot of the way that my attendings, people, in leadership roles have seen the Latino patients and Latino population. And I also dedicated a lot of time to research, particularly around interpretation for patients. And I think that that is another way to try to showcase how I can be in this position, and I am trying to show how they can empathize with our patients despite not having this shared experience.
Well, I want to thank all of you for joining us. I know as doctors, you all have been working around the clock, and that goes for all of our doctors who have joined us this evening. Thank you so much for joining us tonight. So we'd also like to say thank you to our literary performer, Reggie Gibson, for his portrayal of Onesimus. Thank you, Reggie. And now let's hear from the president and CEO of the Museum of African American History.
Thank you for joining us for Race in the Public Dialogue, sponsored by Liberty Mutual and in concert with our partners, GBH Forum. We also invite you to look at our website, where you'll find even more resources related to this evening's production. And then please join us on our campuses in Boston and Nantucket, where you see a true reflection of artifacts and materials and art and letters related to those brave abolitionists who were so impactful in shaping American history as we know it today. Thank you.
I'm Dr. Christina Greer. Thank you for spending some time with us. Be well.